These are very extraordinary circumstances which we are facing this year because of the coronavirus outbreak. I know you all are missing your classes and we are also missing you all. But look at the brighter side of it that you are home with families and you have seen the epidemic with this experience you will not get perhaps in your lifetime again. So do study this epidemic. Since you are missing your classes, we have tried to make the videos and the PowerPoint presentations for the practicals and the lectures, which we will be sending you on a weekly basis. Please go through it. If you have queries, please do email us, which we'll try to solve in our own way and as we get the time. Hope you like it. If you have any suggestions, please pass on to my faculty by emailing them to my department. Thank you.
Hello everybody, my name is Dr. Chaitanya and today we are going to learn in the practical about the COPD in lung tumor. This is the presentation regarding the briefing of the practical. So what you have to write down in your record book is the definition, histological classification and other points which has been shown over here. Coming to the next is the topic of today's practical, but before that we will learn quick review of our anatomy of the lung. There are the two lungs in the body. They are the right lung and the left lung. Right has been divided into three lobes, that is the superior lobe, inferior lobe and the middle lobe, whereas the left lung has been divided into two lobes, that is the superior and inferior lobe. So now lung has been well connected with the trachea, as we all know that, and trachea can be divided into principal bronchi, bronchioles and the terminal bronchioles. So below the terminal bronchioles we have the respiratory bronchioles and alveolar duct, and the alveolus are also called as the sac. This sac is lined by the two types of cells, that is the type 1 and type 2 pneumocytes. This together is called as the acinus, which is the functional unit of the lung. And this anatomy is very important because if bronchus and this terminal bronchi are involved, then it goes to the terminology called as the bronchiectasis, whereas the below anything about this terminal bronchi is involved, then it is called as the emphysema. So this is anatomical importance of learning this thing. Now coming straight forward to the topic, that is the COPD or chronic obstructive lung disease where it has been divided into the 4 points, that is the bronchiectasis, emphysema, chronic bronchitis and asthma. Out of these two things come under the medical terminology and these two things come under the surgical terminology. Why is so? Because these are the chronic condition and treated by the medical drugs. So coming to the definition of the bronchiectasis has been divided into bronchiectasis can be defined as the abnormal dilation which is a permanent or irreversible of the bronchioles and the bronchi. Just now I have explained you. And the emphysema is the permanent dilation of the anything distal to the terminal bronchioles. So bronchiectasis may be diffuse or local. So coming to the specimen of the bronchiectasis, it is the wet mount formalin preserved specimen which is measuring around 18 into 10 into 3 centimeter, and the pleura shows mild thickening, whereas the cut surface shows many dilated, and the bronchioles which are in the upper part of the lower lobe and the lower part of the upper lobe, and there are the anthracotic pigment deposition also. Or coming to the emphysema specimen, which is also a cut section of the lung showing the mild pleural thickening, but important thing is it is showing the bleb formation which are subpleural and measuring around 0.3 to 0.5 measuring around the 0.3 to 1.5 centimeter in diameter. So the lung is voluminous, so that is important terminology in case of the emphysema, that is the volume of the lung is increased in case of the emphysema. So etiopathogenesis of the both things, that is the bronchiectasis and emphysema, are the different. Bronchiectasis may be due to the infection or other causes, whereas in case of the emphysema again it may be inherited or non-inherited causes. So please read this from your textbook, and it has been covered already for you in the theory lectures also. So coming to the specimen which I already explained you, we can see again that is this is the specimen of the bronchiectasis which is showing dilated bronchi and the cyst which are of around 1.5 centimeter in diameter, whereas in case of the emphysema there are the bleb formations. Hope you are appreciating this, because if I am zooming this, the quality of the picture is going down, and there are the some bleb. This is not the bleb, this is the artificial thing while taking the photograph. So what we learn, I will conclude in the very small thing, that when you see the lung which is showing the dilation of the bronchioles, and there is a one lung which is showing the blebs under the pleura and the voluminous. So bleb with voluminous lung, it is diagnosis of the emphysema, whereas the bronchial dilation, it is called as the bronchiectasis. So these are the two gross differentiation of the lung. Coming to the next topic of our practical, that is the histological classification of the lung tumors and the some specimens. So lung tumor has been divided into the two parts, that is the benign and the malignant. So benign can be adenoma, papilloma, hamartoma. Malignant can be squamous cell carcinoma, adenoma, then small cell carcinoma, large cell and carcinoid. The another two things which I should include in the lung tumor is the mesenchymal tumor, and the last one is the metastasis. So this is the full classification. Metastasis is the second most common tumor in the lung. Squamous cell carcinoma is the first most common tumor in the lung, and then followed by the adenocarcinoma. Adenocarcinoma can be bronchogenic or bronchoalveolar carcinoma, but newer classification of the adenocarcinoma shows that adenocarcinoma can be divided into three parts now, which is called as the pre-invasive, invasive and minimal invasive. So pre-invasive carcinoma is called as AAH or adenoma in situ carcinoma. Invasive is called as the bronchogenic adenocarcinoma, and minimal invasive or microinvasive carcinoma is divided into again the mucinous and non-mucinous parts. So invasive carcinoma can be histopathologically seen as a micropapillary, papillary and lipidemic growth. So this is the newer classification which has been covered for you in the theory exclusively. So please remember at least this classification. I just revised the classification only. So coming to the specimens, there are the three specimens which we are going to learn today in the practical, that is the bronchogenic carcinoma, bronchoalveolar carcinoma and the lung metastasis. These three specimens we have in our laboratory. Coming to the one by one, that is the bronchogenic and bronchoalveolar carcinoma. Here you can see that the tumor is going from bronchus sides to the pleural surface, and the margins are the irregular, which are yellowish white in color, measuring around 4.5 to 4 into 5 centimeter and having the irregular margins. Whereas in case of the bronchoalveolar carcinoma, again the tumor is starting from the bronchogenic side going to the periphery, but the infiltration in the parenchyma shows that the solid and grayish mass. So this is the main difference, that irregular margins and anthracotic pigment by which you can identify your bronchogenic carcinoma, whereas the mass infiltrating arising from the bronchus and infiltrating your parenchyma and around 4 into 0.75 centimeter, then it can be a bronchoalveolar carcinoma. So these are the two specimens, and then the last one is the lung metastasis. Lung metastasis is easy to identify because it shows that the multiple lesions, here you can see single lesion, here you can see that there are the multiple lesions which are well circumscribed, having the grayish or creamy appearance, and these are the circle of various size around 1 to 0.5 centimeter differential diameters. So these are the specimens. Here in this case, when we are describing the lung tumor specimen, one thing remember, that don't comment on the pleura whether it is thickened or not, whether instead of that comment that whether pleura is present or not. For example, in this specimen you have a pleura which I have cut while doing the editing of this figure, but in this case you don't have a pleura which is already stripped off. So these are the two main differences which you should learn and talk about when you are describing the specimens. Whereas in case of the metastasis, you can see that clearly multiple lesions which are having variable size. In this case here you can see even the necrosis also in this lesion, which is not appreciated very well, but when you see or look for the original specimen you can easily understand. So these are the three specimens from the neoplastic lesion: bronchoalveolar carcinoma, bronchogenic carcinoma and the lung metastasis. Whereas in the non-neoplastic lesion you have to learn about the bronchiectasis, emphysema. So thank you very much.